everybody. It's just after 10 o'clock, so I think we'll go ahead and get started. I know we're going to have a lot of questions for our speaker today, and I want to make sure we have plenty of time for that conversation at the end. So for those of you who haven't been with us or haven't joined us yet, this is the May Ask the Expert series from Dementia Alliance, North Carolina. I'm Lisa Levine, the Director of Education. We're so happy to have you. We could not be doing this without our partners from Aging Outreach Services and Garner Law, and we are thrilled to have Jennifer Tyner, who was our speaker on both of our Tuesdays, Jennifer Garner, who is our Thursday speaker, Susan McKenzie from AOS, and today we have Ashley as one of our panelists as well. We're so thankful you're here to help us out, Ashley. So I'm going to go ahead and let Susan say hello. We'll jump right into Jennifer's topic because I know there's going to be so much for all of us to learn.
Good morning, everyone. Aging Outreach Services is so excited to be a part of this series. I know that you're going to enjoy this final one. We invite you to visit our website, to read our blogs and participate in the education that we try to provide the community. Our job is to help you age successfully. And with that, and much thanks to Dementia Alliance, I'm going to turn it over to Jennifer Garner.
Thanks, Susan. It's great to be with everybody again today. This is a newer presentation for me, so hopefully it'll flow as smoothly as last week's did. But I just wanted to start off with a quick reminder that I am a North Carolina licensed attorney. So everything I talk about today is going to be based on how I advise my clients here in North Carolina. Anything that I am commenting on today should not be taken as direct legal advice. As you well know, everybody's situation is very different. And also anything that I do answer for you online today through the chat box is certainly not in any way forming an attorney-client relationship. Just have to give my little ethics speech there. So let's jump in and get started. I have a lot to cover today, and hopefully I will answer most of your questions as we go, but jump into that chat box, and I've got all of my wonderful helpers from Aging Outreach and Dementia Alliance to help me watch my chat box and interrupt me with questions as needed. I don't mind the interruption at all, and we'll move through multiple different areas and different benefits programs that might be of some help to you. So we're going to start off with, if I can get my computer to work right, we are going to start off with the Medicare program. So the Medicare program is a federal program. It is a federal program that is part of what I refer to as entitlement programs under the federal government. So if you worked and you paid into the system through payroll deductions, Social Security system / Medicare payments, then when you reach a certain age or you have certain disabilities, you qualify for your Medicare benefits. Medicare is a very complex program, of course. All government programs usually are, right? So it consists of 4 major parts. Part A, which is part of what I refer to as traditional Medicare, that covers hospital services. Part B, which again is considered part of traditional Medicare, and that covers doctors, labs, and x-rays. Part C are what we refer to as Advantage plans. Those are rather new, especially in North Carolina. And those plans are a public and private partnership. And then you have Part D, which is prescription plans. Those prescription plans, again, are a public and private partnership, so they do work a little differently. We're going to talk about each one of these parts of Medicare in the next few slides. So in Part A and B, as I mentioned, those have no private partners. That is an entirely government-run and government-based program. They do retain the services of some private companies to process what you're probably used to getting which are EOBs, your explanation of benefits forms. Those might come from United Healthcare or other providers, but the rules, regulations, and the funds for this program are all coming from the federal government. Again, it is an entitlement program. It is not something that is under the welfare umbrella of the government. If you have worked, if you have paid in, if you were married to a spouse that qualified, then you have entitlement to those benefits. When you have Part A and B, they don't cover everything. So they are similar maybe to a major medical benefit that you had when you were working. And in that, I mean that they pay a portion of it. So let's say that I go to the doctors and the doctor is providing a service that she likes to charge $300 for. Well, if she accepts Medicare and I'm a Medicare patient, then the Medicare might say that they think that that procedure is worth $200. And she has to agree to accept the $200 value for her services. So that's a Medicare write-off right off the top. If you have looked at any medical bills for folks that are on traditional Medicare, you'll see the doctor's charge of $300. You'll see the Medicare set off or change in fee. They'll take off that $100 they don't approve of, and then they'll pay 80% of the remaining $200 doctor's bill. Well, the other 20% can still get expensive. So most of my clients that have Part A and Part B, traditional Medicare, will also purchase what are called supplemental policies. Those policies are purchased out in the marketplace from your regular insurance agent. They are private policies, and there are multiple different plan types. If a company is going to offer supplemental Medicare benefits and sell those policies, those benefits have to fit into one of the approved plan types by the federal government. So when do I get my Medicare benefits? Well, if I'm approved for Social Security disability, which we certainly see a fair amount with early onset dementias, and once somebody is on Social Security disability income through the Social Security Administration, in month 24 of the receipt of those disability benefits, they receive their Medicare card. So they are entitled to all of their Medicare benefits month 24. So even if they are disabled at age 35, age 50, once that 24 months of approved disability passes, they receive their Medicare benefit. Otherwise, if you don't qualify for Social Security disability, you are entitled to receive your Medicare benefits starting at age 65. You want to get in touch with Social Security Administration to begin those benefits and make sure that you have all of your ducks in a row through the Social Security Administration to have that go into effect. And you also want to be sure that you're out shopping for supplemental programs at that same time as well, to be sure that you're ready to start at 65. So how does Medicare Part C work? Well, Medicare Part C is what we call the Advantage plans. So when you opt into Medicare Part C or one of the various Advantage plans, you are actually giving up your traditional Medicare. And I'm not sure that everybody understands that, because the people that sell Medicare Advantage plans, as most of you have probably experienced, do an incredible amount of marketing. They grab you in Walmart, they mail you flyers, they send you all kinds of information in mail. And so I know they're pushy. And you have to be careful. You want to be sure that you really do want to give up Part A and Part B and opt into the Medicare Advantage plan. Because it's a public and private partnership, the public piece of it is that the funding that you would normally pay for your Medicare Part B benefit actually goes to these private companies from the government, and then the private company covers you. So each private company has its own Medicare Advantage plans, as long as they don't violate the basic rules. What you want to be careful about is understanding what those premiums are for that Medicare Part C plan. They can go from a 0 premium plan up to premium plans that can be as high as you were paying for your supplemental insurance. The big thing is that Medicare Part C operates much more like a major medical plan prior to receiving Medicare benefits. And what I mean by that is that there usually are deductibles, out-of-pocket maximums, and there are copays. So if I have a client that needs to go to the neurologist and the therapist and see a PT person and go by their doctors very often, those copays certainly add up and become much more expensive than traditional Medicare with a supplemental payment. You have to remember that with Medicare Part C, there will be pre-approvals and certifications required in order for you to receive certain benefits. And those can be difficult to go through, both for your physician, for your hospital, or for any nursing home that you're trying to transition to, because it is not an entitlement. You have to prove that you need that. You have to prove that maybe you've tried other drugs or other methods or other less expensive things that you could do for whatever your particular ailment or problem is before they'll agree to pay for it. So there's open enrollment once a year. That open enrollment runs from January 1st to March the 31st. That is your time frame when you can either give up your traditional Medicare A and B and switch to a Part C Medicare Advantage plan, or if you've chosen to receive benefits under a Medicare Part C Advantage plan and you prefer to switch back to traditional Medicare and locate a supplemental policy to pay the difference, that is also the time of year that you do that. I usually recommend to my clients that they meet with a very trusted insurance agent privately, either the same one that does their cars and autos or their life insurance, or assist them with investments, or if they don't have a close contact there that they can trust, then I usually recommend that they visit a local insurance agent that they can sit down with, and maybe one that's independent and can run various options for them through their system and get multiple quotes, so you really understand what it is that you are doing. I believe this year and maybe last year, they extended the open enrollment period because of COVID and people not being able to get around and make decisions and go places they needed to for advice on that. With Medicare Part D, that is prescription coverage. Again, it's a public and private partnership. It's been around in North Carolina a little bit longer than the Medicare Part C plans have. So people have gotten a little more used to it. Premiums, again, can go from 0 premium up to, there's really no max, so high premiums. And with Medicare Part C and Medicare Part D, those private entities that want to be involved in providing that coverage have to be approved for that area. So you'll notice if you do any research online, or even if you're with your insurance agent, they're going to be asking you specifically where you're located and probably start off with a zip code search. That is because there are only certain companies that get approved and that have plans in various areas and various states. The annual enrollment for Medicare Part D is October 15th through December 7th each year. And I highly encourage everybody to reshop your Medicare Part D benefit each year, because probably your prescriptions have changed, as well as the company actually changing their drug formularies. So those companies can decide what drugs they will cover and what drugs they will not cover. So with your particular ailment, you may be prescribed something that is new, maybe something that doesn't have a generic for it, and you may find that there's no coverage or little coverage. One of the ways that Humana and some of the others have sort of gotten into the marketplace is by covering some of those drugs the initial year. So I think it might have been before Aricept went generic. they had great coverage, for example, for Aricept. And so everybody kind of ran to them because as they looked through the drug formulary and the different tiers of drugs and payments and copays, wow, they're going to cover it and I'm only going to pay $10 a month for that drug. Well, sure enough, as predicted, they dropped that drug in year 2, but most people didn't know to go in during open enrollment, which again is October 15th through December 7th, and actually recheck and see what drugs were covered and which drugs were not covered. So you do want to check the drug formulary each year. You can start by checking the plan that you're with so that if they're still covering everything nicely for you, you don't have to worry about a change. There are drug tiers, so most of these plans will have tier 1 through tier 3 or tier 4, and each tier has a different copay for you. So in addition to knowing whether they cover your drug, you want to understand which tier your drug will be in, and it's amazing how different that can be. I could have an Aricept prescription, and one company will have it as a tier 1 drug, and I'll have a $5 copay, and another company might put it in tier 4, and I have a $50 a month copay. The Medicare.gov site, .gov site is extremely helpful. I really haven't found anything that is more helpful than that site. Each year during open enrollment, when you go in, make sure you have your traditional Medicare card with you. You'll need the numbers off of that to set up your own little account in Medicare.gov. It is secure. Remember that it does have to be .gov. If you type in Medicare.com, Medicare.org, you're going to find all kinds of private companies that have bought those websites and domain names, and they will definitely take advantage of you getting all of your personal information from you. But have a list of your medications, what you take, how often you take them. And if you put that in, it will actually pull up specific to your area or specific to a drugstore that you wish to use, which plans actually offer coverage in your area and what kind of coverage they offer you. The column that I always look at is the column that says, what is my total annual cost? Because we tend to go for no premium plans, but those no premium plans likely have much higher copays every month. So it might be that you choose a plan that has a $40 premium payment every month, but your drug only costs, $10 a month total. So you actually end up better paying a premium and paying less for the medication every month. So Medicare.gov, very helpful for that Part D enrollment. Some of your Part C plans offer the Part D coverage as part of the plan. You can certainly do that together, or you can shop them separately. I recommend that you at least shop them separately so you know whether you're paying more to Part C to cover your prescriptions as well. So does Medicare pay for a nursing home? Very little. So let's talk a little bit about traditional Medicare Part A and B and what they might help you cover if you were going to a facility. They never cover anything in assisted living unless it is something like maintenance rehabilitation, which is actually under your Part B coverage plan. So in order for any Medicare benefits to kick in for you to go to a nursing facility for rehabilitation or for permanent care, you have to have been admitted into a hospital for at least 3 days prior. Now, if we think about flu season and the OR's full, the hospital's full, a lot's going on there, they might hold you in the ER room for a day. That is not being admitted to the hospital. It's only when you're actually admitted into the hospital itself and basically given a room assignment. So in the hospital for 3 days, 3 midnights, as I call it, and then you transfer out directly to the nursing facility. It needs to be for some form of rehabilitation, whether that's going to be physical therapy, occupational therapy, speech therapy. and you get into that facility, into a rehab bed, your traditional Part A and B will cover day 1 through 20 in full. That means if the doctor stops in to see you, if they bring you in medication, if they bring in a mobile x-ray unit to take some x-rays of your chest, all of those things are covered by Medicare if you still have your traditional plan. When you get to day 21 through 100, Medicare will pay a portion of your care. If you have a decent Medicare supplement, you will usually have full coverage for day 1 through 100. So Medicare Advantage, just remember that Medicare Advantage, if you're going from the hospital to the nursing home, you have, oh, I got a typo there. Sorry about that. You have pre-qualification and recertifications that you have to go through. So if you are a caregiver or a child who is named as a healthcare power of attorney, you have to get ready to put on that armor and go to battle. You have to work with those doctors and those discharge planners, as well as with the nursing facility. Number one, to make sure that the nursing facility does in fact have a contract with this Medicare Advantage plan, and that they will accept that plan. Because just because they accept Medicare does not mean that they have to be registered and accept the Medicare Advantage plans. So make sure that the nursing facility that you're choosing to transfer to from the hospital does accept your particular Medicare Advantage plan, and then start working with everybody as quickly as you can to make sure that you meet all of the pre-qualifications and understand when you have to be recertified. So I've seen it as short as 5 days, and that's really stressful. They'll authorize 5 days in the nursing facility for the person being transferred. And so really on day 2, you have to start submitting paperwork and arguing with them again about extending that certification for you. And at that point, there's not a lot of information. The therapist hasn't seen you multiple times, and it can be hard to get recertified. Just be ready to push. And remember that there's no entitlement. So there's no entitlement under that Medicare Advantage plan to your 100 days maximum of therapy that you can receive at that time. And I'm sorry about the typos. It was really late last night when I was putting this together, and I guess I just knew what it was supposed to say. Want to mention the GMO settlement case to you all because it is very important. Sort of unfortunately, the government decided to settle this case rather than allow it to continue through the court process, where we could have used it as precedent and actual law. But we do all still fight based on the terms of the settlement and what Medicare was supposed to do to make sure that it is enforced the best we can. The Center for Medicare Advocacy has a fabulous website. They have self-help kits in helping caregivers and healthcare power of attorneys the ammunition they need to try to get their loved one their 100 days of coverage. So what most of your nursing facilities are going to say to you in your patient care meetings is that your loved one is not showing improvement, and therefore we are going to have to give you a notice that Medicare is no longer going to cover this care. Well, that's not true. That's not really what the law says. That's what they've been trained to do because their corporate heads are worried about not being paid or not being reimbursed by Medicare. As most of you know, the Medicare system is kind of slow. You can go to the doctor and not receive your EOB for a month or 2 and not know what they paid your doctor for 6 months. So of course, these nursing facilities get very concerned about the backflow of funds and whether they'll be paid. So when someone is not showing improvement, they like to issue the family a notice that the Medicare payment's going to stop. Medicare payment. I thought I said Medicaid for a minute. That the Medicare payment's going to stop and that you need to start private paying. But the true standard is that as long as that benefit and those therapy sessions are keeping your loved one at their current level, or if they are preventing a decline, then that person has the right and is actually entitled to their 100 days of therapy. So always be prepared to advocate. As we leave Medicare and we jump into some of the other programs that are going to help you care for your loved one, I want to just touch on, and I know Jennifer Tyner touched on this as well, the 3 different levels of care. The programs and the rules are all very different between those levels of care. And so I'm going to try to cover the different programs within the level of care that we're discussing. So we have independent living first, then we'll pop into assisted living and then skilled nursing facilities. And I'll touch on those benefits as we get into each one. So independent living. Yes, ma'am.
I'm so sorry to interrupt you. Before you go on, there's a couple of questions. So,
Okay.
Billy was told that because her husband has Alzheimer's, he cannot switch out of Advantage and go back to traditional Medicare A and B. Have you heard that before?
I have not heard that before. I think one of the underlying problems with switching back from an Advantage plan to traditional Medicare is that it's very difficult to pick up a supplement. If you drop your supplement and go into an Advantage plan and then try to switch back, they get to re-underwrite you. So they may have denied him in underwriting because of his diagnosis, and that because they're a private company providing supplemental benefits to traditional Medicare, they don't have to accept you. They do have to accept you when you're 65 and you're first coming in. But if you switch and then try to come back, they do get to re-underwrite.
So that's good for all of us to keep in mind then.
Right. Once you leave, you can come back to traditional, but if you don't have a supplement, that can be very expensive because you have to cover that 20%.
Okay. All right. And George said that his wife has Medicare with state insurance, which is Humana. And he wants to know if there's any flexibility, or do they just accept the plan as it is?
So if you are getting benefits from your former employer, which I'm thinking there is probably the state of North Carolina's teacher plan, you don't really have an option unless you wanted to give that up and go purchase insurance somewhere, which probably doesn't make any sense monetarily, but the state and most of the private companies are really pushing everybody into Advantage plans and PPO type plans where you don't have as much control. But the state plan is actually a pretty good one in comparison to others.
Okay, thank you. And
Sure.
is the 100 days entitled regardless whether you're using the traditional or the Advantage plan?
Only traditional Medicare A and B is an entitlement. It is not an entitlement for the Advantage plans. The Advantage plans, you're opting out of all of your entitlements and accepting whatever that plan provides.
All right, thank you. That's all of our questions for right now.
Great. Thank you. So as we hop into independent living, that might be in your home, remaining in your home. If that's the case, you probably want to do smart things like have a care manager come by and see what safety issues you might have. You might want to move into an apartment where you don't have yard work and outside maintenance to do, or you may want to move into senior living. There are some senior living communities that you might at first think that they are assisted living, but they are technically independent living. Independent living senior facilities do not have to comply with any type of government regulation like they would if they were labeled assisted living or skilled nursing. The first level of a CCRC, which is a continuing care retirement community, is independent living. So in our area in Moore County, we always think of Belmead, Peanut Village, Pine Knoll, Quail Haven. Those are continuing care retirement communities where you move in, you pay a certain price at the beginning, you're in independent living, whether that's an apartment, a cottage, and then you can shift into assisted living and or nursing facility care. And then your other option with independent living, if you need some help, really your only option is to hire private caregivers to come into the home. If you do have a temporary illness or you're recovering from a flu bug or a knee replacement or a broken hip, you may have some Medicare home health benefits that your physician has to order for you, and home health may come by on a temporary basis just to check on you after a major medical event. Otherwise, you're just doing your private caregivers. So when it comes to private caregivers, I always give my clients the little spiel about whether to use an agency or to use an independent person. I always end up, of course, as an attorney, risk aversion, I always end up with an agency. And my big reason for agencies is that you really have enough on you already. You don't really need to become an employer. You don't need to worry about liability issues, workers' compensation issues. The agencies that most of the ones that I work with definitely do thorough background checks. They have vetted these people. They will do the payroll. They will do the tax reporting. They make sure that liability insurance and other things are in place so that you and the assets that you've worked for and saved your entire life are not at risk because you hired Susie Q from church, who was really nice, and you used to know her grandma, but she comes in and your jewelry box is gone the next day, or she, is helping you shower and says she pulled a muscle in her neck and she's out of work and wants you to compensate her because you probably were not carrying any kind of workers' comp insurance as her employer. So do always be careful on that part. How do we pay for these private caregivers? So you might have long-term care insurance. Long-term care insurance can usually kick in for private caregivers. You may need to pay out of pocket, just pull things from your basic income, from your retirement savings. Or if you were a veteran or your spouse was a veteran, and they served for at least 90 days active duty, and at least one of those days overlapped with a period of war or a period of conflict, which there are set dates for the different skirmishes we've been involved in through the life of our country. There may in fact be an aid and attendance benefit that will help sort of reimburse you for the costs that you have outgoing to care for yourselves in the home. So long-term care insurance. If I have a long-term care insurance policy, what should I be looking for if I want my home care covered? Well, do I have a home health rider? Depends on the timing of when your policy was purchased, how long you've had it, and probably how good your agent was at the time. Hopefully your policy will have a home health rider on it, which can avoid you being forced into a facility in order to take benefits from that policy. Does that policy have any particular agency requirements? So who are you allowed to hire or not hire? Can you hire a family member? Can you hire a private person that you know? Can you hire just an agency? And if it's an agency, what type of agency are you allowed to hire? Does it have to be specifically licensed home health care agency? Can it be a registry? So lots of different things to look at in the terms of those policies. Don't ever just listen to how it worked for your neighbor, because I guarantee you none of your policies will read the same unless they were purchased on the same day with the same agent through the same company. They've all changed over time. Most of your long-term care insurance policies will have a deductible period. That causes a lot of my clients some heartburn, but what I always remind them is that if they're in a facility, then that deductible period is probably the time that you're there for rehabilitation purposes and strengthening, and that's probably going to be covered by Medicare if you have your traditional A and B coverage, and possibly some of it be covered if you are in a Medicare Advantage plan. I like to think about long-term care insurance. Most of the policies that I've seen go into effect are more like a reimbursement plan. So go ahead and get your services started, file all of your paperwork. Most of the agencies are very helpful in helping you complete the paperwork and pull everything together, because of course they want you to be reimbursed so that you can afford their services. And some of the policies will actually pay the agency directly. So instead of sending you a check to reimburse you, there are some agencies that will allow you to assign that benefit to the home care agency, so you have a little less paperwork to do along the way. But the main thing with long-term care insurance is to consider when you want to use it. I encourage people probably the sooner the better, unless you have some unusual terms in your policy where you can only use it for a short period of time, or it only covers 6 months or a year of care. Then we wouldn't want it to kick in to help with the gal that we have come in to help 3 hours a week. We'd want to wait until we needed more substantial help, but that will help you stay in your home if you happen to have that policy. Out of pocket, if you're paying out of pocket for the people coming into the home to help you in independent living, then of course it's your savings, your retirement. Some of my clients will use a reverse mortgage, and it has worked beautifully for some of them. Reverse mortgages can be expensive to put into effect at the front end. But if you know for sure you're going to remain in that house is safe for you to remain in, that you've installed grab bars in the bathroom, that you have a walk-in or roll-in shower, that your house is on one floor, that you've got family or other support systems in place to make sure that you have groceries and meals prepped and medications delivered. It can be a beautiful thing to stay in your home until the end. And this reverse mortgage allows you to pull the equity out of your home to use for your care without having a monthly mortgage payment to make. And sometimes we see family members that chip in to help. So if you've been fortunate and raised children, maybe who've gone off to very successful careers, then maybe this is the time where they would like, even for tax reasons, to make you one of their dependents. And they can cover more than 50% of your costs and write you off on their tax return. So if you've got one of those wealthy kids out there, that might be an option for you as well. So I'm still in independent living, and I've got some people coming in to help me, and I'm wondering if I'm eligible for any veterans benefits. Well, you need to be sure that you understand that if you are a veteran, there are multiple different types of branches of the Veterans Administration that might provide you with some assistance. And by no means am I covering all of them, but the ones I thought would be important to you today. You can enroll in the healthcare system. You can see doctors there. You can go to the VA hospital. You can receive nursing care through the VA, and you have to just enroll in the healthcare system. Depending on your community, you probably have a Veterans Service Office. In Moore County, we have the Veterans Service Office located in Carthage in the Agricultural Center, and they are absolutely fabulous. They will walk you through the different benefits you may be eligible for, and help you with all of the application processing, and then they'll keep after the VA to make sure that you get your answers. Some of the prescription coverage under the VA health system is wonderful. A lot of my clients will still see their primary doctors at the local facilities and just head over to the VA maybe once a year under the healthcare system, just to sort of get them to either rubber stamp the prescriptions that are already in place from their primary care, or add anything extra that they need, and then they just do the mail order prescriptions through the VA for very low cost. Disability, there's a disability section of the VA. If you have any service-connected disability at all, they will help you seek a disability rating. And once you receive that disability rating, you actually receive a disability check. Once you have received that check for a certain period of time, if you pass on as the veteran, a portion of that check will actually continue for your spouse. So anything they can tie back to a service-connected injury for you may be very helpful. One of the things I didn't mention with the healthcare system, there are some benefits for glasses and hearing aids. And I know those things can be very expensive privately. So that's also another reason to consider the healthcare system. Pension, VA veterans benefits, there's something called a pension. There's different levels of pension. There's a base pension. There's a homebound pension. These are basically just income supplements provided to veterans who might be low income, low assets, and homebound, trapped in the home, need services, need people to come in and provide basic needs or take them out to facilities. The top level of pension is called aid and attendance. And that's the one that several of my clients have applied for successfully, for either assistance with covering home health care agencies in their homes or helping to cover a cost at a assisted living facility. It doesn't give you enough money to even begin to help with long-term care skilled nursing facilities. So I usually tell people not to waste their time fighting the federal government for benefits on that one. So the VA aid and attendance pension, they do have to review your income and look at your household income. And they also review your assets. And there are limitations on both of those depending on which program you're applying for and what type of assets you have. You have to have expenditures on certain healthcare items, reoccurring healthcare items, and you have to prove that all of those expenditures exceed your income. So if I'm hiring Susie Q to come into my house and provide services to me, bring in my groceries, prep my meals, make sure my pill bottles are all sorted and ready for me, and that bill from the home care agency is exceeding my monthly income, then I may be eligible as a veteran for up to $2,295 a month if the veteran and the spouse are in that home. If I'm a widow of a veteran, then my maximum benefit is $1,244. I sort of think of this program as a reimbursement program. It can take a while for these applications to get through the federal government. I was a VA certified approved attorney for a number of years, and I went ahead and let that certification drop because there are just some parts of the government that you just can't battle. And it just became very discouraging and very depressing, actually, to me, not being able to get my clients' benefits as successfully as I thought I would be able to. And the other reason is that we just have such a fabulous veteran service office here that there was really no reason for me to be involved. I could walk the client through it and help them get together what they needed to take, but working directly with the veteran service office was much more successful, and they had much more direct contact with where those applications for benefits were going. It's harder for us outsiders to get in. So let's assume, another typo, I'm so sorry, guys. Let's assume that we're transitioning to assisted living. So what's assisted living? Well, in assisted living, they're going to provide your 3 meals a day, your snacks, your social activities, transportation to doctor's appointments, and you may have a private room or a semi-private room, lots of common areas in most assisted living facilities, so people just don't sit in their rooms or their studio apartments alone all day. Awesome bridge groups and knitting groups and bingo games and all kinds of good stuff going on there at those assisted living facilities. So how am I going to pay for the assisted living facility? There are different levels of assisted living. We do see clients, especially with dementia, that need to go into what we call the memory care units, sometimes referred to as a special care unit or a secured unit, due to particular behaviors or due to flight risk. They need to be in those areas of the assisted living community, and that's usually secured. How am I going to pay for my assisted living? Well, I could private pay. If I'm going to private pay, I'm going to have to pull from retirement, from savings. Long-term care insurance might kick in and help me pay for that. And everything that we talked about with long-term care insurance applies here in assisted living as well. Same rules, same paperwork, do your application, and then you can either assign it to the assisted living community to help with your bill every month. If your company allows that. If your company doesn't allow that, then you're going to get that check every month and in turn pay the assisted living facility. Special assistance. So special assistance is a North Carolina based program, North Carolina only. If you are in another area, moving to another area to be near a child, or if we have a child on here from out of state listening and thinking that they're moving their parent closer to them, you will need to check your state specific rules. But basically, the Medicaid waiver program is a program that was written and created in North Carolina, submitted to the federal government to ask for funding under the Medicaid waiver, and we were granted that program. So it's North Carolina taxpayer funds, some federal Medicaid funds, and we'll go through that program here in just a second. And of course, if I'm in assisted living and I'm a veteran, or my spouse is or was a veteran, then that veterans aid and attendance may in fact be very helpful, as long as the assisted living facility is keeping you safe, managing medications, providing someone to help you with things like showering and independent activities of daily living. Then the cost to stay there can be considered a medical expense. So if I'm going in and I don't have much in the way of assets or income, what kind of program is going to help me pay for that? And so the special assistance program, again, is a North Carolina Medicaid waiver program, different from the Medicaid program where you would be entering a skilled nursing facility or a nursing home. So they do look at your income, and it is the income of the person who's going into the facility. And they look at your gross income. So you have to look at that income before you have taxes deducted, before your Medicare premium comes out, before you have your Part D prescription plan drafted from it. So the gross amount of your income. Unfortunately, this program has an income cap, and it is extremely low and is not indexed for inflation. And I've been practicing law since 1994, and it has never changed. So unfortunately, that income cap for a regular assisted living is $1,248. So if my gross Social Security check is $1,300, I do not qualify and will never qualify for that special assistance program. If I'm in a memory care unit and my Social Security check is $1,310, then I would be below the income cap because that special care unit cap is $1,581. But even if you're a penny over, it disqualifies you, and there's no way around it because most of our incomes we can't give back. So if you're entitled to Social Security, you're entitled to it and it pays out, and most pensions are the same. So your income is what it is. If you pass the income test, then they're going to look at your assets, and they're going to say, well, what assets do you have that you can pay for this care for yourself before we step in and pay for it under the special assistance program? And that asset limit for that person going into the facility is $2,000. So an extremely low asset limit. You would apply for this benefit at the Department of Social Services office in the county in which you reside. Not a lot of facilities take special assistance, and you can see why. They don't get paid a lot to take care of people. They are allowed to also bill for some other services where they might be providing a CNA to assist with bathing or a specific care need that resident has, but they're not getting a lot for the care that they're providing. So be sure that if you are going to try to rely on the special assistance program, that you are really, really good and careful about which facilities in your community will cover and accept the special assistance program. Most of them, I will tell you, are private pay, but there are some good ones that aren't. One of the unique things about the special assistance program, and please remember that everybody's circumstances are different. Everybody has different assets, different benefits available. So it gets very client specific. But if I needed to go into a memory care facility and I needed to be down to $2,000 in assets, if I had a well-drafted financial power of attorney giving my husband the power to make gifts to himself, he could use that financial power of attorney and transfer all of my assets over to himself, leaving me with less than $2,000, and I could qualify. So I am allowed to give assets to my spouse and still qualify for the program. So sometimes that works nicely and efficiently for our clients. You can't just gift it away to the kids or to your nephew or to the church. There are gifting penalties on the special assistance program. There is a 3-year look back. So it matched the federal law back when the program was created, and there was a 3-year look back for this Medicaid special assistance waiver program in North Carolina. There still is the 3 years, which means if I gave my assets to my children instead of to my spouse, for every $3,000 that I gave to the children, I will not qualify for this program for 1 month. So I have to go chase the children down when I'm in need of care and try to get my money back. So don't count on that. I don't even get change when I send them to pick up dinner. The veterans benefit for assisted living, again, would be that aid and attendance program. You can apply through your veterans service office, and they are usually extremely helpful with that. So let's get into the skilled nursing facility. So if I'm going into the skilled nursing facility, then how am I going to cover my cost of care there? Well, I can private pay, but most of us can't. That private pay cost would be anywhere from $6,000 to, I'd say, $10,000 to $11,000, depending on where you are in North Carolina, and it can be much more expensive in other places around the country. Long-term care insurance, again, if you have a long-term care insurance policy, most all of them cover skilled nursing care. Most of those policies, when they first came out, were actually focused on institutional care. It wasn't until years later that they did those home health riders. And sometimes we can do an alternate plan of care under those policies, allowing the client to actually stay home, even though their policy was not intended to cover them at home. So I have worked with many aging care professionals and care managers before to help write up with their work, my work, and the doctor's work, what we called an alternate plan of care, to convince the insurance company to leave mom at home and be cared for in her home, which would be less expensive for them in the long run, rather than forcing her into institution just because of the long-term care insurance policy. And then the big one that we all tend to go to or focus on for the skilled nursing facility is the Medicaid program. The Medicaid program, there are tons of Medicaid programs, just like we saw the Medicaid waiver program to help with assisted living. There are Medicaid programs for young children, for pregnant women, all kinds of different Medicaid programs, but the one that helps you pay for a nursing home is the age, blind, and disabled long-term care type benefit through Medicaid. So Medicaid is a federal program. Medicaid started at the federal level. They created the framework for this program. They set aside a big pot of money, and they went out to the 50 states and said, hey, does anybody want to participate in this program? We will give you your share of the money, but you have to comply with all of our rules. So North Carolina said, yes, we'll do the Medicaid program. Give us that chunk of money. They come back home. The North Carolina lawmakers create their plan as long as they stay within the federal framework. They create their own Medicaid plan because they have to contribute North Carolina tax money to that program as well. And then they pass it on to the local government because it is administered through the Department of Social Services. So how do I qualify for Medicaid? Well, you apply at the Department of Social Services, but you don't want to run up there and apply until you know that you've done any planning that you want to do, or until you have met with your estate planning or elder law attorney to review the application process and make sure you're not going up there too early. We don't always want to go too quickly. So it's a 3-part test. You have to medically need to be in a skilled nursing facility. So if I want to go into a long-term care facility because I want the Medicaid program to pay for my care, but I don't need long-term care, I could easily be cared for in a facility of a lower level, like an assisted living facility, then Medicaid's going to say, no, you can't come here just because we would pay the bill. You don't need all of this care. A lot of my clients are in the gray area on that. And so we work closely with the doctor's offices and care managers to make sure that the FL2 form, which is a government form that gets completed by the doctor to establish your level of care, gets filled out correctly. So we usually tell the doctor what we're hoping the answer will be at the bottom of the form, just in case you or your loved one happen to be kind of in a gray area between 2 different levels of care. So if we pass that test and the doctor agrees that we should be in a skilled nursing facility, then they're going to look at our income. No income cap here like special assistance. So we don't have to worry about those numbers we looked at earlier. They're going to look at all of your income sources. So that could be your retirement, your Social Security, that could be money you get from stocks or bonds or investments. You could have rental property, you could lease your farm, any type of income that you have, you report to them in that Medicaid application and provide them with proof. And as long as your income is lower than your cost of care, you should pass that income test. There's no cap. So if we get through the medical and the income test, they're going to look at our resources and they're going to say, well, what have you got? What have you saved up? What's sitting out there that could help us out here without the government having to pay for this? So I'm sure you're already seeing a big difference between Medicare and Medicaid. Remember, the reason is that Medicare is an entitlement program. You paid into that program, you worked, they withheld taxes, that money is in that Social Security Medicare system for you to pull from later when the timing is right. On the Medicaid side, that is what we call a welfare program. And the welfare program uses tax dollars to assist those who can't assist themselves. So rules are completely different between those two programs. And typical government, they name them Medicare and Medicaid, almost the same, so that we can easily get confused. So again, income was all sources, but they do only look at the income of the institutionalized spouse. They don't look at the income of what we call the community spouse, the person staying at home. So you still usually report your income as the community spouse in case you're entitled to part of the institutionalized spouse's income for covering your costs at home. But they're not looking at you as the healthy community spouse to contribute any of your income to your spouse in the facility. Your resources in this program include all of the assets of the individual or the couple, or the couple. So if you're married, they're going to look at both of your resources, all of your assets combined. Doesn't matter whose name is on the account or who earned it or where it came from. If you married for better, for worse. And this is one of those worst cases that everybody has to struggle through there. The institutionalized spouse can only have $2,000 in assets. So when we talked about the special assistance program, I said if I needed care in the special care unit, And all of my husband had the right powers under a financial power of attorney to be able to remove my name from those assets and move them to his name alone. That worked for that program. That doesn't work here because they count all of the assets of both spouses. So let's go through and talk a little bit about what's countable and what's non-countable. So non-countable, that means they're not going to take this into account when they evaluate whether you are eligible under this asset provision or not. So your home is exempt, and there's certain limitations, but your home place is exempt as long as your community spouse is living there. Or if you are the surviving spouse or the last one to go to a facility, if you or your representative declare that you have an intent to return home, then there is no forced sale or forced transfer of your home place. You are allowed to keep a vehicle. There's no limitation on the value of that vehicle. So if you're like me and you've always enjoyed driving your older cars that you got used to, that sort of became a part of your family, this is your chance to run out and buy that brand new BMW and hide all of your savings inside of a vehicle title. Not a very good financial decision. They depreciate quickly, but you can keep a vehicle. Personal property and household furnishings. If you are not collecting diamonds as an investor or gold bars as an investor, then your other items in your home are your personal property and your household furnishings. So maybe you have 3 diamond rings, but those are not investments that you are making. That's because you like to wear diamond rings. There's no need for you to inventory and declare anything as a countable asset when it comes to your personal property and household furnishings. So burial plots, you can have burial plots for yourself, your spouse, and immediate family members, and those are not countable. You can have an irrevocable burial contract. That is a special type of burial or cremation contract that you do with your funeral home of choice. And it's just irrevocable, meaning that you can't run in there the next week and have them give you back a check. They have to provide the service, of course, but they don't have to return your money. So we always like to get those done when we're doing a Medicaid spend down plan. Tenants in common real estate. So let's say that years ago, you and your spouse went in together with another couple to buy a lot in Pinehurst so you could be members of the Pinehurst Country Club and get those tickets to the US Open. And you all own the property together with them. That is not a countable asset on your Medicaid application because the government cannot force the other couple to liquidate that lot to create assets for the sick spouse's care. Rental property with some limitations is also an exempt asset. The government's thoughts there are that if you have this property and it's producing income for you, then that income is yours and it's being reported and it's going towards your cost of care. So they don't make you dispose of your rental property. It does have to earn a certain percentage of profit a year over and above the maintenance and the upkeep, the taxes and the insurance. So there is a little formula. You can't just rent it to your neighbor for $1 and make it non-countable assets. Life insurance, if the face value is less than $10,000, that life insurance can be kept. And business property, as long as you or your community spouse are still active in that business, then your business property is not countable. Again, the thought there is you're creating income. That income is going towards the care of the person, so they don't make you divest yourself of that business property. Now, countable, basically countable is pretty much everything else that I didn't mention. But bank accounts, cash that you may have, investments, whether that be stocks, bonds, cryptocurrency, anything that you're into these days, your IRAs, your 401ks. I do caution people that there are other states that don't count retirement funds as an asset. So for example, if you've got a daughter living down in Georgia, that might be the child you decide to go live near, because last time I checked, Georgia did not count IRAs or 401ks or any kind of retirement funds as a countable asset. If you have extra vehicles, so as a spousal unit, you each had your own vehicle, this is the time where you have to choose one vehicle. You can sell both and get that new BMW we talked about, or sell both and get a Bentley. Or you can just keep the one that you love and like and get rid of the other one, and then that becomes a cash asset. If you have life insurance that you own and the face value is over $10,000, then the market value or the cash value of that policy is actually a countable asset. So we sometimes have to do some conversions there or some sales of policies among family members. Any real estate that's not exempt, so it's not tenants in common, it's not producing income, it's not your home place, then that of course would be a countable asset, and pretty much everything else that you can think of. Now, do we as elder law attorneys move things between the countable and non-countable column? Of course. The goal is to make as many of those countable assets that you may have non-countable assets, especially when we're trying to protect as much as we can for the healthy spouse at home. So let's talk a little bit about what is protected for that healthy spouse, that community spouse that is not moving into the facility. So of course, the exempt assets are set aside as exempt. So the spouse can certainly retain those. And then they can keep half of the countable assets on the snapshot date. That's called the community spouse resource allowance. So they're allowing that spouse to keep resources. So what is the snapshot date? So if I have a client that I'm working on a Medicaid application for, and they went into the hospital on January 10th with a broken hip, had surgery, recouped at the hospital, transferred to the nursing facility, that means that they have been in a continuous period of institutionalization for 30 or more days. So they didn't come home, they didn't go to assisted living, they went straight from a hospital to a skilled nursing facility, and they've been there more than 30 days. And I'm applying for them to be covered by Medicaid benefits. Then the date that I'm looking at is going to be the value on December 31st, because my client broke their hip on January 10th and they haven't been home since then. So the first moment of that month, which was January 1st at 12:01 midnight, is that snapshot. So those values, when the market closed on December 31st, or the bank closed, or you put your cash in a jar and buried it in the backyard, whatever asset we're looking at, that value on December 31st is what we're going to add up. So if I add all those assets up for this couple and I have $300,000, then my sixth spouse, remember, can only keep $2,000. So I'm going to have their half, they're going to have $148,000 too much. And my healthy spouse has $150,000 allocated to them, one half of the whole. And they're only allowed to keep $130,380. You see that maximum number on my slide. So we would have to spend $20,000 of their money and $148,000 of the institutionalized spouse's money. And what do you know? They owe $175,000 on their mortgage. So what a beautiful Medicaid plan. We pay that house off, and that community spouse no longer has a mortgage payment hanging over their head. And that sixth spouse automatically qualifies for Medicaid care because they have met their spend down requirements. So just as a brief example to show you how those numbers work. So what income is protected for that community spouse? So what if my husband is the breadwinner in the house and has the larger pension and the larger Social Security income, and maybe I had stayed home with the kids for years, and I only have a Social Security check and a really small pension from the county where I worked before I stayed home to raise my children. So I'm going to be in a panic because even though I have the house and I have my car and I have some savings, how am I going to upkeep that? Where's the money going to come from when the county tax bill comes in? Well, I'm entitled to an income of no less than $2,155. So if I have $1,000 in Social Security coming in, that means they're going to allow me to take $1,155 of my husband's income before I have to give the rest of his income to the nursing home. So that is the base amount. And that's called the monthly maintenance needs allowance. And if I want to have that allocated to me as the community spouse, I need to complete that Medicaid application with all of my income information and what my basic needs and basic shelter expenses are. So what is my average utility bill and water bill, and how much is the homeowner's insurance? And maybe I live somewhere with homeowners dues and things that I have to pay in order to keep my house. And they would allocate some funds to me. There are some times where expenses of a particular home or particular community are excessive, and there are some creative ways of possibly petitioning to have additional funds moved over. Can I give away my assets? So the short answer is no. There is a 5-year look back. So if I am being placed in a skilled nursing facility and my family is applying for Medicaid benefits for me, they will look back 5 days. I'm sorry, 5 years. I wish it was 5 days, 5 years, and see if I have given any gifts away. Now they're going to ask me or ask my loved one who's doing the Medicaid application under the penalties of federal perjury, whether I have given anything away or not, but they're also going to audit my financials up to 5 years to look and see if they see a bunch of checks written for $15,000 the day before Christmas, for example. Or they're going to look at the property tax records and say, well, we saw that you had a second home at the beach and it's no longer in your name. Where did it go? If I have not been paid the fair market value for those assets. So if I had a beach house and my beach house is no longer in my name, they are going to ask me for the records surrounding its sale. If I sold it for what was considered the fair market value, then I would be okay because those funds would be in a bank account and I would be disclosing those funds to them. However, if it turns out that my children are the recipients of that deed, and I can't show any funds coming in for them to have purchased that beach house for me, then I will be penalized for having made a gift within that 5-year look back. They calculate that gift based on the average cost of care. And so the average cost of care in North Carolina is $6,810. So for every $6,810 that I gifted away, I will incur a 1-month penalty. So my family then has to get extremely creative in either bringing me home and taking care of me or figuring out how to return assets to me so that I can pay my own private way through my penalty period. If I gave my beach house away 6 years ago, it's never going to be an issue. But remember, if I gave my beach house away and I gave it to my children, then I don't have any right to go there to vacation there. And they may very well have sold it, mortgaged it. They may have gotten divorced. And now my ex-son-in-law and my ex-daughter-in-law own that beach house or a portion of it. So if you give it away, you give it away. Here's a gifting example. So mom and dad gifted $100,000 to their son in 2020. And then unexpectedly, dad has a problem and goes into the nursing home a year later. Of course, that gift was within the 5 years. So the caseworker at the Department of Social Services would sit down And she would say, okay, you gave $100,000 away. We're going to divide that by 6810. We get the 14.68 months. And under these new federal rules, they actually count the 0.68 months, which would be 20 days. So I have 14 months and 20 days that I have to figure out an alternative way to pay for my care. So hopefully that son is just as sweet as can be and writes that $100,000 check right back to mom and dad. And we move right along with maybe some alternate planning. So one thing before I get into the hospice benefit that I want to mention, North Carolina and all states, actually it's federal. So the federal law says that if there are any assets left in the estate after the Medicaid recipient has received benefits in a skilled nursing facility. So I'm in a skilled nursing facility, I qualify for Medicaid and I pass away. If there are assets in my estate, so if I had a life insurance policy and I had named my estate the beneficiary, or I still owned part of the home place, I still owned part of the lot that I bought with my friends, then those assets are actually in my estate and they're going to pass through my will or through my trust. And Medicaid is required by federal law to file a claim in my estate to recoup the money they have spent on me. So there is a lot of planning that needs to be involved, not only to become eligible for Medicaid, but to also make sure that you are protecting any of those exempt assets and any additional assets that we shifted to the exempt column in one way or another. We need to protect that from the claim after death. And so there's a lot of asset transfers and retitling of assets that needs to take place relatively quickly after the qualification to make sure that assets don't come back to me. So an easy example, I own my house with my husband. If I was in the nursing facility qualified on Medicaid, I want to be sure that he has power of attorney for me so he can act over my financial matters and my assets, and that power of attorney has specific gifting provisions in it, allowing him to give himself my assets. So he could go to an attorney and have a deed drafted. He could remove my name from the title to the house so that it was in his name alone. Then he could change his will and make sure that if he died before me, that he didn't just give it back to me because now I'm on Medicaid, and maybe he would leave it directly to the children. So number of things you have to plan for to make sure that Medicaid doesn't come back in the end and just gobble back up the assets that you thought you had protected. It's called estate recovery. Another Medicare benefit that you don't want to forget about under your traditional Medicare and under most of your Advantage plans, you have the right to accept a hospice benefit. And it is a great thing to do if you're nearing the end of your life and you have a terminal illness and you just need all of that extra support around you and your family and your loved ones. You can opt in to the hospice benefit under Medicare. So what you're doing at that point is you're saying, I'm not going to be over here at my doctors and my specialists running up all kinds of bills under my Medicare benefits because I know what I have is terminal and I know they can't fix it. And I want to live the rest of my life with quality and pain-free and with my loved ones and people around me. And I'm opting in to the Medicare hospice benefit. They will pick up and pay hospice for those hospice and palliative care measures under my traditional Medicare benefits. So it is a great thing. I can't say enough about hospice and palliative care benefits and providing quality of life for the patient as well as the family. They usually have a team of doctors, nurses, social workers, everybody that you kind of need surrounding you and your family and supporting you at that time. So if I haven't completely confused you, I'm going to stop talking and I'm going to ask Susan and Lisa and Ashley to kind of glance at that chat box for me and see if we have very many questions popping up there.
Jennifer, we don't have a lot of questions right now, and I'm sure that's because everybody is processing everything that you just shared with us. There was a question earlier. Do you know, or can you give us a ballpark for what it might cost someone to stay in memory care and also in long-term care? Is there like an average monthly
So,
rate?
you know, the government thinks that the average for a nursing home for skilled level of care is $6,810. And I mean, technically that is a number that they did come up with in a valid manner. But even in our community, I can see a skilled nursing center at, you know, $5,000 to $6,000 a month. And then I can also get a bill from a different one that's $10,000 a month. And that's within the same community. So, you know, some of that might be private room versus semi-private room. But most of that is really just the finances of the facility itself and what you're comfortable with and where you prefer for your loved one to be. And by that, I don't mean that the care is, you know, there's not really a $4,000 difference in the care that you receive. The regulations are the same. The staffing requirements are the same. You know, one might look pretty fancy and have a fancy dining room and fancy wallpaper, and the other one might be a little plainer, but it's same type of facility. For assisted living, I think you can kind of see the same thing. We have a couple of options in our local community where you might find assisted living around $4,000 a month. And then you can go all the way up to, you know, $6,000 or $7,000 a month. And that depends on the memory care unit versus regular assisted living. But then it also depends on the size of the apartment that you choose, whether it's private or semi-private, and whether you need any of the add-ons. So medication delivery, whether there's any incontinence issues and you need folks assisting you with changing more often during the daytime, whether you need someone in your room when you're showering because you're a fall risk. So those are usually all add-ons to the base rate at assisted living.
Thank you for that. Allison added in the Triangle area, it averages about $8,500. She didn't specify skilled nursing or assisted living, but still, wow, $8,500. So I know we have a lot of people that come into Dementia Alliance and they just assume that everything's going to be paid for by Medicare and Medicaid.
Mm-hmm.
They just kind of think that's everyone's fallback. And from what you said today, it sounds to me like you're really telling everyone they need to plan ahead. They need to talk to an estate planning attorney, elder law attorney to go ahead and make sure everything's in place so that they're ready for all of the look back and all of those other things. I know that a lot of people seem to fall in what I've heard called as a donut hole, or a place where they don't really fit for any of these programs.
Mm-hmm.
Do you find a lot of that when you are helping people plan? Do you think that without these plans ahead of time, more people, you know, fall into that gray area?
I do. So when you hear about the donut hole, that is a term that is actually in the law on the Medicare Part D program with the prescription drugs, where you know, they provide so much benefit and then you have a chunk where you have to completely private pay. So that's where that one came from. But I see a lot of people that need assisted living level of care. And the only program that'll really help you out there much is that special assistance program. There's such a shortage of facilities and beds available for that program because the reimbursement rate from the government is so low under that Medicaid waiver program And so many people don't qualify for it anyway, because their Social Security checks exceed, regardless of their other income, the Social Security check exceeds those income caps. So I think there's a great need for people to be in assisted living, but they don't really have the funds to write the $6,000 check a month, and they don't have a program to turn to. So they either stay home and try to get by, or if they're sort of in that gray area where we can qualify them for skilled care, then they would probably qualify for the Medicaid program for long-term care nursing. But as you can sort of see, the government programs push you towards institutionalized care, which is really not what anybody wants, and is actually more expensive for the government, in my opinion, than if they had a program to help people avoid that institutionalized care. It's just not there.
Okay. Uh, we have a question from Dana. Is hospice and palliative care an option only when someone has 6 months to live?
So palliative care is not. That is something you could probably get help with prior to that. Hospice, technically, a doctor is saying that you could die within the next 6 months. And so that's not, nobody really knows. I mean, I love when my clients have to be recertified for hospice care. It's a great thing to outlive your life expectancy or outlive what they were expecting you to live for. And their goal is not to in any way assist you or push you to dying any sooner. It's just providing quality of care. And dementia patients can qualify for hospice. It's not as easy as a terminal heart condition or a terminal cancer diagnosis, because we all know dementia is just a much harder illness, depending especially on what types you may have, to pinpoint what's going to happen and what's going to happen next and how quickly are we going to decline. But dementia can certainly affect our gait and make us a fall risk, and obviously a safety risk, and hospice benefits are in fact available. I encourage clients to look into it and talk to their doctor for a referral sooner rather than later, because I see often that they wait too long, and the social worker and the volunteers and all the people that could have been there getting to know the family and really helping them through this process have missed out on that opportunity when they're just there at the very end.
I would so agree with you. I think sometimes people don't even think about the 6 months. They wait to the very, very end of life.
Oh, yes. I've had clients, we get them all signed up and registered and they pass the next day. And it's just sad, because it's a wonderful program that really helps you and your family work through a lot of the grief and the anger and all the different steps of having a terminal illness and losing a loved one prior to when it happens.
And like you said, people can need to be recertified because they've gone past that 6 months. People can even graduate, if you will, from hospice.
Exactly.
Yeah,
Yep. I've had several clients graduate. They kind of get everything under control, and the cancer's not as aggressive, or, they've been doing really well with monitored care and support. And, you have a hospice nurse that you can reach 24/7. You don't have to bounce back and forth to the ER and the house. And, you can get into some of those constant visits where you feel like it's just a rotating door over at the emergency room. And every time you enter that emergency room, you're susceptible to catching something else. And it just becomes a downward spiral. But with hospice care at home, you've got your doctors, your nurses, your bathing aides, your social workers. Everybody's right there wrapped around you, helping you whenever you need it.
It's definitely a great service for everyone. So we don't have any more questions unless Susan or Ashley would like to ask anything. But
Jennifer?
yeah, go ahead, Susan.
Jennifer, this is Susan. I've got a question for those of us that are smart and we talk to an elder care attorney when we turn 60 in the 60s. How often should we meet with our elder care attorney to reevaluate our healthcare changes, our financial changes? Is there any guidance that you can give us?
So with the elder law piece of it, I don't have a specific answer, but the general estate planning groups all say that no less often than every 3 years, you need to do a detailed review of your documents. Now, that might be that you and your spouse sit down at the kitchen table and say, we're going to get that packet out from Garner Law Firm. We haven't looked at it in 3 years, and we're going to see who in the world we were put in charge of us and how everything was set up. And maybe a quick email or call to the law office to say, you know, it's been 3 years since we've seen you. Have there been any major law changes? So from a legal perspective, you know, either you read it on the front page of a newspaper or you hear a big new tax act passed or a new Medicare, Medicaid provision passed, you might want to check back in. With the elder law piece, it's a little bit harder. It's usually a major shift in your family itself, a diagnosis of something that you know will be terminal and or a major change in your assets. So maybe you've lost a child or had 5 new grandchildren born. Maybe you have been diagnosed with a form of dementia or with a terminal heart condition, and maybe you invested in all, I don't know, all cryptocurrency and it's all gone now. So you've had major changes since you sat with your attorney last. That should certainly prompt you to go in and meet again, or provide updated asset sheets and contact information to that attorney's file. I met with a spouse within the last few weeks that I hadn't seen since 2002, and he'd recently lost his wife, and it was a little bit of a struggle for the two of us to catch up. And I hated to have to keep asking him for all these updates and all of this information. When he was, you know, having such a difficult time, I could have been so much more helpful to him if I'd had updated family information or updated asset information. But, you know, it'd been 19 years since they chose to come in and do any kind of updates and discussions.
Thank you. That's just a question we get asked as a company a lot. So I appreciate the
Sure.
question.
So I thought there'd be a million questions. I hope that doesn't mean that I lost people. It was a lot to cover, and government programs are always very difficult. I struggled with how to put it together to present it without trying to jump around too much. But if people have questions later, they know how to find all of us.
They definitely do. And I have to tell you, I hear a lot of these talks, and you're one of the speakers on this area that I can follow. And I tend not to get lost when you share with us. Whereas there are, and then I'm just being truthful, there are some other speakers on this topic where I sort of zone out and go, oh, wait, I needed to hear that. And I don't do that with you. So thank you so much for working so hard to engage all of us. We don't have any more questions that have come in right now. So I would invite people, if they have questions later, definitely to reach out to any of our hosts and we will help you find that information. We thank everyone for joining us, and we thank Jennifer Tyner. We especially thank you, Jennifer Garner, for all of your time and your expertise. We know how busy you are, so thank you for sharing this with everyone.
Thank you. I hope it's helpful to some of you. I admire all that you're doing for your loved ones and all that AOS and all that Dementia Alliance does for everybody. So you guys do a great job.
And these presentations will be sent to everyone. The slides will be sent to everyone and the recordings will be made available. So thank you all so much for joining us. Thank you to Susan and Ashley, and thanks again, Jennifer. We appreciate it and hope everybody has a great day.